Hello.
Hello, Harald Krentel, how are you?
I'm fine, thank you. How are you?
Thank you very much. We are very fine. You are at hospital, I think.
Yes, I'm in my office.
Oh, okay. You are in office.
Yeah. Yes, I just finished surgery for today.
Ah, really? How many surgeries did you perform today?
Today I did 4.
4. Oh,
Yes.
and only endometriosis or other surgeries?
Today it was exclusively endometriosis. Yes, but
Endometriosis.
usually I also do oncosurgery. So
Oncosurgery. Yes, you are also an oncologist, I think.
yes. But today it was it was a bowel endometriosis, and then we did a niche repair surgery too. So the classical things.
Did you make a bowel resection, discoid or segmental resection or shaving?
Yes, we did. We call it nodulectomy. So what we did was, you could call it shaving, but it's like we tried to do a complete resection of the nodule. Yeah. So it was a complete resection of the rectal wall, but without opening the mucosa.
Mucosa, yes.
So the mucosa was intact, and then we do one line of a suture with a barbed suture of the muscular.
Reinforcement suture.
Sorry?
Reinforcement suture.
Yes, yeah.
To prevent leakage of the bowel.
Yes, exactly.
Do you see very frequently the urinary endometriosis in your hospital or Germany?
Well, urinary is not that frequent. We have a lot of bowel cases, but bladder and ureter is less frequent.
Less frequent, yes.
Yes.
Why do you think that the urinary endometriosis is a little bit less than bowel endometriosis? Do you have any idea or opinion about this topic?
Well, I think that mostly when we see endometriosis, it's the posterior part of the pelvis.
Yes.
So I think this is the explanation. I don't know why, but it might be logic that the pouch of Douglas is the place where everything accumulates. Yeah.
Accumulating, yes. The anterior is much more mobile than the posterior side. Yes.
Yes. Yeah.
The lesions is mostly located in the posterior side. That's true.
And ureteral disease is very rare, so this is not very frequent, actually.
It is also sometimes very difficult to differentiate extrinsic or intrinsic endometriosis, and clinically, preoperatively, it is really difficult.
Yes, that's true, but in most of the cases, I think the ureterolysis is the best approach.
Yes, most of the cases, yes.
Yeah. So a stitch is something that we do, but not very frequently.
I think you are performing rarely the ureteroneostostomy. We in Turkey we rarely perform ureteroneostostomy. Yeah. Ureterostomy is much more easy and much more convenient for most of the patients.
Thank you for inviting me.
How is the weather in Germany? I think in Turkey for 3 days it is very snowy and very rainy.
Yeah, here it's the same. It's we have now the temperature is under 0, and it's there's some snow already. Yes.
Hi Harald. Hi Ahmet.
Hi Engin. Good to see you. How are you?
Good to see you.
Evet hocam, dinliyorum, buradayım. Sizi izliyorum. Bir sıkıntı yok.
That's really good.
Yes, I'm happy to see you.
How is family? Everything's okay?
Yes, we are now one person less at home because my daughter now moved to Vienna because she started to study. Yeah.
You told me.
Yeah. So we are just now my wife and our son, and it's different now. He is happy because he's only child for the last years until he's going to leave the house too.
He is the prince of the home. That's very, very important.
Yes, now he's only child prince. Yes. Yeah, but
how is the Duisburg hospital?
Yeah, the German hospitals have some economical problems right now. There's a big economical issue, and they want to centralize a lot. So some hospitals start to close now because they can't do it any longer. And I think it's a good thing, because we need a much stronger centralization in Germany. And I think we are on the winner's side with our hospital, because we have highly specialized departments. So we will survive this, but for the next 2 years, it will be a bit difficult. So it's a kind of fight in German hospitals.
Big competition.
Yes.
Yes. Okay. Thank you for today.
Yeah, thank you for inviting
Thank you
me.
so much. It's a pleasure for us. Thank you so much.
Thank you.
Ahmet,
On time,
2 minutes.
We will begin on time, I think. We have 2 minutes to begin to our webinar.
Okay. We will be disappear. Thank you.
Okay, thank you very much. Uğur Bey, 1 minute later, we will begin to our webinar. I think you will share the screen of the Dr. Harald Krentel. Okay. 1 minute later. Okay, now it is time. We are beginning our meeting. Good evening to all my colleagues. Welcome to our webinar organized by the Turkish Endometriosis and Adenomyosis Society. The topic of tonight's webinar is the medical and surgical management of adenomyosis. Our guest is the Dr. Harald Krentel from Duisburg, Germany. I would like to share Harald Krentel's resume with you. Dr. Harald Krentel is specialist for gynecology and obstetrics, certified gynecological oncologist, and certified specialist in minimally invasive surgery. He is specialized in surgery in deep endometriosis and gynecological cancer. He performs surgery in deep endometriosis of the colorectal and urinary tract, including nerve-sparing techniques in the deep retroperitoneal space. Krentel is specialized in hysteroscopic and laparoscopic procedures in adenomyosis, including adenomyomectomy and cytoreductive procedures in infertility. Currently, he is the president of European Endometriosis League and head of Department of Gynecology, Obstetrics, Gynecological
Kızım, toplantıdayım. Ne var?
and Senology at Duisburg,
Git
Germany.
iç o zaman.
Could you mute?
Su ablandan iste.
Professor Kale, we cannot hear you. Could you unmute your microphone, please?
Okay. Could you hear, Dr. Taner?
Yes,
Okay.
very well.
Okay, I'm going on. Currently, he is the president of European Endometriosis League and head of Department of Gynecology, Obstetrics, Gynecological Oncology, and Senology at Duisburg, Germany. I would like to remind my colleagues that you can write your questions in the message box during the webinar. Please don't hesitate to ask any questions regarding the subjects. Dr. Harald Krentel, again, welcome to our webinar from Germany, participating and being with us. Stage is yours, please. We will be happy to listen to you.
Dear Ahmet, thank you so much for your kind introduction, and thank you very much for inviting me to give a talk in your webinar series. I'm really honored, and I'm happy to talk about adenomyosis tonight. And I'm sure there will be lots of questions because unfortunately I cannot give you so many answers, but I will try my best. Please, when the connection is not stable, just let me know immediately. I hope everything will be fine during my lecture. So I hope that now you can see the screen.
It's fine now.
Okay. Yeah, so adenomyosis is something that is really relevant, and mostly in the last 10 years, we have been talking a lot about endometriomas, about deep endometriosis, about bowel endometriosis. And when we want to counsel our patients with endometriosis, peritoneal disease, or deep endometriosis, of course, we also have to think in adenomyosis. So this should be principally always part of what we do with our patients. In this publication, which is not a big thing, but it shows some data, we proved that many of our patients have adenomyosis. And in this cohort, which is a hysterectomy cohort, we found 40% of cases with adenomyosis. And when you go into details and you screen for those patients who had bleeding disorders or dysmenorrhea, the key symptoms of adenomyosis, then the rate almost reached 60%. Of course, this is hysterectomy cohort, which means that it's a bias of pre-selection, but still I think it shows, like other studies, that adenomyosis is a quite important and very frequent benign disease, and that the uterus might play an important role in patients with endometriosis. And another important detail is that when we talk about adenomyosis, it's a disease across the lifespan of our patients. So we can find adenomyosis, symptomatic adenomyosis in teenagers. Of course, we find adenomyosis in patients who want to become pregnant, and it's a big problem for the surgery, but also for reproductive techniques. And of course, we also find adenomyosis in symptomatic patients around the perimenopausal age. And I could put a fourth video on that slide, which is a postmenopausal adenomyosis, which also might cause problems. And then, of course, we have a lot of different types of adenomyosis. So, for example, in this case, we are talking about a 31-year-old patient with an adenomyosis of the anterior wall of the outer myometrium, which is connected to the bladder and which is causing symptoms, but which might also be related to the infertility of this patient. And here are another example. So there's on the left side an adenomyosis of the posterior wall, which is connected to the bowel and to the rectal endometriosis nodule. And on the right side, there's a cystic lesion of the inner myometrium. So you see that there are different types of disease, and according to the type of the disease, there are special symptoms and also effects on fertility or infertility. And what we still do not exactly know is which type of disease and which extent of disease is causing which kind of problem. So this is something that we need to find out in the future, and we need a unique classification system for adenomyosis, because when we say the word adenomyosis, this can mean a lot of different types of disease. as I mentioned, it could be diffuse disease or focal disease, inner myometrium or outer myometrium, or cystic adenomyosis or polypous adenomyosis. So there are different types. And I think it is very important for us to find a good classification system which could work in surgery, in ultrasound, and MRI in order to classify. And then we have to relate this classification to the symptoms and also to the impact on patients' fertility. As you can imagine, disease of the inner myometrium, let's say of the junctional zone, of course, is causing a different impact on fertility than the disease of the outer myometrium. So without doubt, we have a lot of problems caused by adenomyosis. As I said, highly frequent disease. It's the central reproductive organ which is affected. Most of the patients are symptomatic. There's without any doubt a negative impact on fertility with reduced pregnancy rates and reduced birth rates and higher abortion rates, also in assisted reproduction. And there are quite a lot of recent papers on obstetrical risks and complications due to adenomyosis. So the disease itself gives some risk of uterine rupture, premature rupture of membranes, and postpartum hemorrhage. So all these obstetrical complications can be related to adenomyosis. So some people start to say, if you have a pregnancy in a uterus with adenomyosis, this is a high-risk pregnancy. When we talk about infertility, which has been controversial in the last decade, I think now we are quite clear, and there's a quite recent review by Pados and the group from Thessaloniki, which is analyzing the literature, and it clearly shows that adenomyosis has a negative impact on patients' fertility. And they also explain some possible mechanisms. And as you can see here, there's also some impact of the inner myometrium, the junctional zone, and the different anatomical levels of the disease. So what do we need to deal with adenomyosis? The first thing is that we need a good diagnostic approach. And actually, it's the same approach that we also use in endometriosis. So we start with the symptoms and the gynecological examination, and then the gold standard to detect adenomyosis is the 2D transvaginal ultrasound. And this can be then added with a 3D scan, if possible, and of course with MRI. But MRI is more expensive and not always available. So the used first-line approach is the 2D transvaginal ultrasound examination. When we talk about ultrasound, we rely usually on the criteria that have been published by the Musa group. And this publication shows us the different ultrasound signs that we can find in patients with adenomyosis. And these papers are all open access, so you can go through it and really find all the details in there. And there are quite a lot of different signs that are common and typical in patients with adenomyosis, such as a globular shape of the uterus or asymmetrical thickening of the wall, cystic lesions, fan-shaped shadowing, and so on. And the problem is, was and still is, that we do not exactly know which of these signs is the most reliable one. So, for example, we see one sign, can we then conclude, okay, this is adenomyosis, or do we need 2 signs or 3 signs? That's not clear. And the problem is that then we have overdiagnosis and underdiagnosis of the disease. That's why in 2022, the same group published a revision of the criteria and divided them in direct signs and indirect signs, which means that when you find subendometrial microcysts or subendometrial echogenic buds, myometrial cysts or myometrial hyperechoic islands, these are the direct signs, and then you can be very sure that you see adenomyosis. When you see, in contrary, just a globular shape and nothing else, then it might be adenomyosis, but maybe not. So it also could be a leiomyomatosis or whatever. So I think this is important to distinguish these signs. We did a study too and published it in ultrasound this year, and we found more or less the same results. So we also found that the direct signs are the most important signs. One of the important signs that we added was the heterogeneous myometrium, which is clear. And we also found that, for example, when you go for globular shape or asymmetry, that then this might misguide you to the diagnosis adenomyosis, but still pathology cannot prove it. The most important ultrasound sign that we found in our study was the subendometrial microcyst that you can see here in this image, which is a very small cystic lesion like an endometrioma in the ovary, but just a very small one. And I think these are quite easy to see in the scan. And here's an example of the same patient. Here you see some hyperechoic spots. Here you see another cystic lesion, and in Doppler ultrasound you can prove that it's not a vessel. And in these videos you also can see a lot of different ultrasound signs. So here this is a diffuse adenomyosis, and you can see the asymmetry of the uterus, you see the cystic lesions, you see the hyperechoic regions, you see the fan-shaped shadowing. So in this uterus, you can clearly see different signs, not just one, but a lot. In this uterus, there are also different signs, like a lot of subendometrial microcysts, hyperechoic spots, and different signs of adenomyosis, but this uterus is not globular, and there's no asymmetry. Yeah. And here you have the question mark sign. You have a very thin anterior wall and an enlarged posterior wall, but no other signs. So it might be that this is adenomyosis, but we cannot be sure. And here the uterus maybe is a bit globular, and there are some hyperechoic spots in the subendometrial zone. So yes, I would say this looks like adenomyosis too, and so on. And here are some more examples. Here it's clear, and you can see that the cystic lesion has a white lining, and the white lining corresponds to the endometrial layer within the cyst. And in this case, you can see a lot of small cystic lesions. So this is clearly adenomyosis. And when you have a patient like this, and this patient is infertile, and you have the problem that the implantation does not work, then it's because of the change of the junctional zone through adenomyosis of the inner myometrium. And I give you two more examples of very young patients. The uterus looks quite normal, very normal, I would say. But here you can see the small cystic ring. And this is an early sign of the disease, and here the same. And of course, we need to change a bit our way to do the ultrasound scan, because usually we just focused a bit on the myometrium and the endometrium, everything okay, then ovary, and that's it. So now the approach is different, and we need more time. We need a special education for that. Maybe we need to include 3D because it's an important option. But this means that we need also workshops and education on ultrasound, because this is something that was not common in the past. We concentrated a lot on surgery, and when we talk about endometriosis and adenomyosis, we always talk about surgery, but we need to get better in diagnosing the diseases. And I think this is a long way to go, and we need to include this to our curriculum when we teach residents and young fellows. And of course, then when we are so excellent in diagnosing the disease, especially in teenagers, then the question is, and has to be raised, okay, what will we do with those patients? So how can we now save the uterus from having a problem in the future? Because the 17-year-old girl is not thinking in pregnancy right now. And she is going to think in pregnancy maybe some years later, and we know now that there's an adenomyosis problem. And of course, then we have to see what can we do to save the uterus and to support, to find a supporting strategy in order to avoid symptoms and future problems in infertility. And the ultrasound gets some new details too. So in this paper, for example, they are not talking anymore about how to diagnose adenomyosis with ultrasound. They start to talk about how to evaluate the treatment efficacy of the adenomyosis and the severity of the disease. So now we are following up the disease with the ultrasound. And in this paper, our colleagues reviewed the possibilities to find different subtypes of ultrasound diagnosed adenomyosis and IVF outcomes. That's what I told you in the beginning. So I think we are on a very good way. And when we look back 10 years earlier, adenomyosis was not that relevant, but now we are focusing more and more on this special subtype of the disease, endometriosis. When we talk about the treatment options, then we have to try to find out if we have several options and which option is the best. So we can go for direct reproductive approach, or we could try to do a medical treatment and then a reproductive approach, or we can also add surgery to our way to go. But these questions cannot be clearly answered as there are no randomized trials on that. And when you go through literature, one of the latest publications is this review, which is really a very comprehensive paper on all the treatment options that you have for patients with adenomyosis, with the aim to preserve fertility. And it's a very long manuscript and very detailed. And this paper shows you all the options available. And it also tries to explain the characteristics, and it gives you special notes on every treatment. So I think this is really a relevant review. But it also summarizes that what we need, of course, is some more data, especially randomized trials, to find out in which way we can help best our patients. So what is clear is that the treatment of adenomyosis, with whatever medical treatment or surgical treatment you go, you can have a nice reduction of dysmenorrhea and irregular bleeding. So usually the treatment works. But what we don't know exactly is where is the effect on fertility. And in a very quite old publication from 2012, Sunkara says treatment of adenomyosis has a positive effect on fertility. Yes, okay, but which kind of treatment and how do we treat? So which are the options? We already mentioned this: medical, surgical, reproductive treatment. And which are the factors for decision-making? Symptoms, family planning, age, and additional deep endometriosis. I would like to give you some examples. So let's see what we can do with LNG IUDs. And usually what we know is that the LNG IUDs, like in the classic dose, help us to treat symptomatic adenomyosis in patients that already gave birth, and now they are symptomatic, but they refuse hysterectomy. So you can offer a Mirena, for example, and they might be happy with the treatment. Okay, but what about very young patients, like a teenager, a 21-year-old woman, and she wants to conceive maybe in 8 years? So can we also use LNG IUD to protect the uterus from adenomyosis, from worsening? I don't know. It might be a good approach, but we have no data on that. So this is just a logical idea, and I know that a lot of people are doing this, but it seems that in these patients, we also need to use the classical dose, the 52 milligram dose of levonorgestrel, because the low dose LNG IUDs do not have the same effect, although they are smaller. So the best solution, in my opinion, would be a very small intrauterine device, which could be easily inserted to a very young uterus with the same high dose like the large IUDs have. And in some patients, it might be helpful to use the LNG IUD in the post-surgical situation. For example, you do a surgery for deep endometriosis, and you know that the patient also got adenomyosis, but you won't do surgery, but you know that the patient needs like 6 months of healing because you opened vagina, you did maybe a bowel resection, and she needs some time to be okay before she can continue or start with assisted reproduction. So you could offer your patient to use an LNG IUD meanwhile, maybe for 6 months, just to get a supporting effect on the adenomyosis problem of the uterus. Dionogest also plays an important role, and there are quite a lot of papers that show that there's a positive effect on adenomyosis. But our impression is, and that's also mentioned in the package of Dionogest in the adverse reaction section of the information, that it can cause uterine bleeding. So when you mix Dionogest with adenomyosis, a lot of patients then start to have bleeding disorders. And for many patients, this is a reason for stop using this kind of treatment. So in my opinion, it's not the best combination. Yeah, sometimes you're not sure if your patient has an additional adenomyosis, and you start to treat endometriosis with Dionogest, and then they start to bleed, and then you know that it's adenomyosis. The GnRH analogs, it's like the classical treatment, and of course it works very well. So you can use it in the pre-surgical situation in very large diffuse adenomyosis cases. This makes sense. We do not do this in fibroids, but yes, in adenomyosis, it's a possible approach to shrinken the disease and to maybe have a better result. I think it's also a good option in the post-surgical situation. As I mentioned before, when you did a complex surgery on the uterus, and you know that this uterus, before the patient could become pregnant, needs some months of wound healing, then you can use GnRH analogs as a down regulation during that time. I would always suggest to talk about this approach with the reproductive team, because they might have another opinion. So it's important that as a surgeon, you also ask your reproductive specialist, do you agree? Is that okay? How is the AMH level? Is that fine that we use GnRH for 6 months? So I think this is important, but it could be a good concept for the wound healing period. Then the stimulation starts and so on. And of course, in some cases, GnRH could be also a continuous treatment. like in combination with at-back substitution in selected cases. And of course, in adenomyosis, it still plays an important role in pre-assisted reproduction protocols, like the lung protocol that still is in use in adenomyosis patients. And then, of course, we have still recent papers on that. Another approach is now upcoming, and it's the GnRH antagonists, which also play an important role. And so far, to my knowledge, we have the Linzagolix and Relugolix approach. This is a paper from 2021, and it shows that the treatment with Linzagolix in patients with adenomyosis is effective and seems to have a good result. The uterine volume decreases. The symptoms also decrease, so there's a positive effect. And this recent paper shows the same effect on adenomyosis for Relugolix, and from the same group from, I'm sorry, I think I missed one slide. There's a recent paper from Jacques Tornes from 2023, and it's like the continuation of the study from 2021, and it shows the same effect, and this is also visible in Relugolix. So I think this is a new approach, and we are using it. Some patients have problems like side effects, but I think this new approach as a pill, as a combination pill, is better to handle than GnRH analogs with at-back substitution. So this is really much easier to handle, as it is oral intake and not the subcutaneous injection, and then you have to see what you do with the at-back substitution. It's much more complicated. So what about surgery? When we do surgery in adenomyosis, we can reduce symptoms. And when we do surgery on focal disease, we can do this by laparoscopy or hysteroscopy. And when we do diffuse adenomyosis surgery, we should do this by open approach. And the last time we always see in the conferences also laparoscopic surgery on diffuse adenomyosis, but sometimes it's really hard to see the videos because the uterus does not look that beautiful after finishing the surgery, and I'm always worried about uterine rupture. So maybe it's better when you do surgery for diffuse disease that you do it open. Another new approach is the robotic approach, and maybe it's easier to handle diffuse adenomyosis with a robot, but we still do not have data on that, and we need to find out. So the question is, what is the optimal surgical technique, and what is the effect on fertility, and do we have risks when we do this kind of surgery? I think hysteroscopy is a very important diagnostic step. We do a diagnostic hysteroscopy in all patients with endometriosis, always. It costs us some minutes, but it's nice also for the residents because they can do a lot of hysteroscopies, and we do not dilatate the uterine cervix. We just enter with a very small hysteroscope, which is usually used in office hysteroscopy, and we do this in the same surgery where we always do the endometriosis resection. And sometimes then you find images like this. So in this patient, you can clearly see that it's an adenomyosis problem. And of course, hysteroscopy can be also used as a treatment option. On the left side, it's a treatment before IVF. I'm sorry, it's not running. Yeah. Not as a first-line approach, but as an option after failed assisted reproduction. So you can see that in both cases, the liquid from the adenomyosis is draining, and the idea is to get rid of this liquid and to get rid of the focal adenomyosis by hysteroscopy. And on the left side, we are using a very small loop, which is just 5 millimeters. And on the right side, as this patient does not want to become pregnant anymore, we are using a normal resectoscope in order to do an ablation of the cystic lesion because she refused hysterectomy. But these approaches are completely individual. So this is no guideline approach. It's just an option when the normal treatment, like medical treatment and assisted reproduction, do not have a good result, then this is an option. And I would never sell this to my patients as a first-line approach, but as an option. Here is another example of a teenager with a lesion in the uterine wall. And I just show this example to you because it shows also a good indication for surgery. In this patient, there was a severe symptomatic situation, and she did not react on hormonal treatment. So that's why we said, okay, then let's do the resection. And we are using a monopolar needle in most of the cases. We did this in ICG mode. That's why there was the green light. And then you see that you can open this lesion, you can take it out of the uterine wall, and then you can suture the uterus. And I think this is a nice approach to do adenomyosis surgery in selected cases. And then, of course, as you all know, there is this kind of Osada procedure, which is a possible approach in patients with a diffuse disease where you want to do a cytoreduction of the disease. Here you see the blue sign during laparoscopy. We did first laparoscopic resection of peritoneal and deep endometriosis. Then we did the chromoperturbation with methylene blue. And the whole uterus was tainted in blue because the blue dye goes into the microtunnels through the myometrium and the endometrium to the uterine wall. And then here in the open approach, you can see that the affected tissue is mostly tainted in blue. But of course, in this kind of surgery, you open the complete uterus. You can see that the cavity is open, the mucosa is open, you resect tissue, and of course, this is related to certain risks. This uterus is quite small. In some cases, it's much bigger. And well, everybody who did that surgery knows that it's sometimes difficult to do. And the most important step is the suturing of the uterine wall, which should be done in flap techniques. And the first step is that you close your mucosa. And then the idea is to do different flaps to not leave any open spaces, no hematomas, and then it might be at the end a good result. Also, hysterectomy is a good option in adenomyosis. So the only thing that we have to have in mind is when we do hysterectomy for adenomyosis and we are leaving behind the deep endometriosis, of course, then these patients will have a persistence of symptoms. And we find this a lot. We really find this a lot. So I just did a surgery yesterday on a patient with a severe deep endometriosis, and the colleague did a laparoscopic hysterectomy for adenomyosis and for bleeding disorders, but they did not resect the deep endometriosis. So the patient was still symptomatic, and it was extremely difficult to get rid of all the deep disease. Yeah. And of course, the same happens when you do resection of deep endo without treating adenomyosis. So this is an example. It's a 55-year-old patient with adenomyosis, with bladder endometriosis, with vaginal endometriosis, with rectal endometriosis. So this is then a hysterectomy, but it's a radical hysterectomy, like you can imagine in cancer surgery. And what you saw with the blue dye is something that we also sometimes use with ICG. So we try to detect the adenomyotic tissue by injecting ICG to the cavity, and then the idea is that the green part is the affected tissue. So we try to visualize the adenomyosis by using ICG. I'm not sure if it really works. In this case, it was okay, because what we resected was adenomyosis, and it corresponded to what we saw in ultrasound. But maybe ICG is not the best tool, as in the future we will have the fusion of our ultrasound and imaging results with the robotic vision, and then it's much easier to see the lesion within the uterus with artificial intelligence, and we do not even need any ICG anymore for the detection of the disease. And this could be the future of robotic surgery. And I'm quite sure that we will see a lot of modern and different techniques, especially in uterine surgery, in the next years. When you look at the results in terms of pregnancy rates and birth rates in patients with adenomyosis, the results are not too bad, of course. But you can clearly see that some of these publications have just 7 patients or 3 patients. Some have 100 patients. But still, they are all case series, and that's it. No randomized trials available. And of course, there's a risk. The highest risk is for uterine rupture. So when you imagine a pregnancy and you have a rupture with 29 weeks, this is a life-threatening event for your patient and the baby. So this is something that we do not want, and we need to counsel our patients on that risk before we do complex surgeries. And without doubt, there are different risks in addition, like placentation failure and so on. So if you go to the very east, to the Asian countries, then you will find that a lot of people now use HIFU for the treatment of adenomyosis and also fibroids. And this might be a very good approach. It shows good results. And we have to consider that all the patients who go for HIFU with adenomyosis are a pre-selected group. And mostly these patients are quite problematic. So when you have a large diffuse adenomyosis, mostly these patients have more than 35 years. They tried to become pregnant. Maybe they had surgeries before. So this is a very pre-selected, difficult group of patients. But still, the results are quite good. Although in May 23, there was also a publication of uterine rupture after HIFU treatment of adenomyosis. So here also we have to wait. To conclude, we have to put all our knowledge regarding endometriosis together, and we have to see what we can do with imaging, with reproductive treatment, with hormonal treatment, maybe with surgery. But we need to have a comprehensive approach when we try to find the best solution for our patients. So we can see adenomyosis quite clear in ultrasound and MRI. So I think the detection of the disease nowadays shouldn't be a problem. We know that there's a negative effect on fertility. And yeah, we need some good training concepts on ultrasound techniques. And of course, when we talk about adenomyosis surgeries, this should only be done in very specialized centers. If you allow me, I would like to invite you to visit us in Bucharest next year in June. We will have a nice conference there, the 7th European Endometriosis Congress. I'm sure it will be amazing. 3 days, only endometriosis, live ultrasound, live surgery, well, and a lot of lectures. And yeah, again, I would like to thank you for inviting me. And yes, I'm open to take your questions. Thank you so much.
Dr. Harald Krentel, thanks for your outstanding lecture. There are some questions. I will directly ask you. One question is coming from the Dr. Taner Usta. Harald, thank you so much for your very comprehensive presentation. Is diffuse adenomyome and focal adenome are they part of the same disease or they are different disease?
It's a good question. I can't answer. I just reviewed. I reviewed as a reviewer for a journal a nice, very interesting publication. I'm sure it's going to be published. As a reviewer, I said yes, it should be published about this question. And this paper tries to find out if first adenomyosis and endometriosis are the same disease or have the same pathogenesis. And then it also discusses the question of the different types of adenomyosis. And the diffuse disease in many cases is related to the outer myometrium and also to severe deep endometriosis. And in some cases, there's also a connection. So you have a connection from the rectovaginal space to the posterior uterine wall to the bowel. And then, of course, it's not easy to say, did the deep endo grow into the uterus, or did the adenomyosis or the uterine endometriosis grow into the bowel? And I can't answer these questions. There are very few papers trying to find out, to find an answer, and but still this is not clear. And I'm quite sure that focal and diffuse disease might be the same disease, but they have a different pathway in pathogenesis, and that's why actually we have a different result than in the phenotype.
Second question is that if there is no clinical complaints for adenomyosis cases, is the diagnosis is important or not with imaging? If there is no complaint for the patients, the diagnosis is important with ultrasonography or any other MRI, important or not for asymptomatic patients?
Yes, it's a good question, and I think it should be we should differ between patients who want to become pregnant in the future and patients who do not want to become pregnant anymore because they already finished their family planning. So in that cases, I think it's not important, of course. So if there's a 40-year-old with adenomyosis, no symptoms, and she already finished her family planning, okay, that's fine. But if the patient is 20 years old and it's not symptomatic, but we can see that there is adenomyosis, then we know that this might be a problem in her fertile life. And that's why, yes, I think we should address it. Yeah.
Okay. Next question is that you mentioned also the HIFU. It might be applicable in some cases and also for adenomyosis cases. Do you think that is there any place for radiofrequency ablation? Does it work or not?
Yes, I think there is a place for the transcervical radiofrequency ablation too, like for example the Zonata system. Yeah, we use it too in some cases. The problem is that when you do ablation of diffuse adenomyosis, you can do different ablation zones. Yeah, when you have a large diffuse disease, you could ablate like 3-4 times in the same session, and then you ablate quite a lot of tissue. And of course, yeah, it works. So the tissue shrinks, the symptoms decrease. But the question is, what is the effect on the integrity of the uterine wall in patients who then want to become pregnant? We don't know. In focal disease, it could also work, but especially in very young patients, I think it would be a good approach. But the problem is that the smallest ablation zone so far is 2 centimeters. So if you ablate 2 centimeters in a posterior wall of a uterus of a 25-year-old, then you will have a lot of damage of healthy tissue. So that's why I think it cannot be used. But I know that the new device will have the smaller ablation zone of just 10 millimeters. And then it might be a better option. In HIFU, and this is the difference, you have a more precise approach. So you can, well, actually it's an ablation too. You can ablate tissue with a precision of 2 millimeters. So that's, I think, the big difference, that it's more precise. Yeah.
Do you think that uterine arterial ligation is effective for older age people or older age women, especially for diffuse adenomyosis? The different
you could do embolization. Yes, that's an option. Yeah, for when patients refuse hysterectomy, that could be an option too. Yes.
Okay. Another question from Dr. Harald. Do you think hysteroscopy is effective for adenomyosis patients except cystic lesions?
Mm-hmm.
Young versus old adenomyosis patients, diagnosis is same or different with ultrasonography? This the two different questions.
Yes. Okay. The first question
is effective for adenomyosis patients except cystic lesions.
Yeah. No, I mean, hysteroscopy has to be seen as a diagnostic thing, I would say. So it's good to know that the cavity is okay, that the endometrial layer looks more or less okay. And yes, if there is cystic adenomyosis, then you can treat it by hysteroscopy. But of course, in most of the cases, as a treatment option, it doesn't work. And the second question, yes, of course, there's a difference. So in the young patients, usually the uterus looks very normal. So a lot of signs that we see in ultrasound and that we can find in the literature are visible or are becoming visible with aging of the patients. So the older the patients are, the better we can find the lesions. And that's the difference. And in postmenopausal patients, you also can very clearly see adenomyosis. And it's interesting because sometimes it's then difficult to say, okay, where is my endometrium? And when you want to check these patients and do control, like for endometrial disorders or endometrial cancer or polyps or whatever, it can be difficult in postmenopausal patients. So yes, there is a difference in age. There's also a difference depending on the day of the ultrasound. So in some patients, in one day, you can see small cystic lesions. And in the next ultrasound, you don't see any cystic lesions, but just hyperechoical spots. And that's why it's difficult to say what you find, actually. But when a cystic lesion becomes a spot, it's because the cystic lesion drained to the cavity. And when you ask your patients, sometimes you can ask, do you have brownish spottings, like chocolate-like spottings? And they will say yes. And that's because of the liquid that is coming out from the cysts.
Okay. Another question, again, Dr. Harald. For diffuse adenomyosis, what is your opinion about Mirena plus progestin therapy at the same time? Combination therapy.
Yeah, why not? Everything that helps is good.
Yes.
I would say that's an option. Yeah, when you do the progestins and then the bleeding disorder starts and you add a Mirena and then the patient is happy. Okay, yes, I would say it's a possibility.
Okay. Another question from Dr. Tolga. How do you manage postoperative follow-up for patients undergoing adenomyosis surgery? Your follow-up after surgery. If you perform adenomyosis surgery, how do you follow up these patients?
Yeah, that's a good question. Yes, we usually well, the German system is a bit different because most of the patients do have a gynecologist, like their home-based gynecologist, and those send the patients to the hospital to get the surgery done. But I usually do not see these patients on a regular basis. But when we did complex surgeries, mostly we invite them to come back after, for example, 2 months or then again 6 months to have an ultrasound scan and to see how is the result. Yeah, and of course we give very clear advices for the reproductive center, for the waiting time until she can become pregnant, and so on. And if there's any problem, of course, they can come back. So, for example, today, I just had a phone call from another German city because 2 years ago, I did an adenomyosis surgery of the anterior uterine wall. It was a deep endo patient and also diffuse adenomyosis of the anterior wall, and we did a site reduction with suture, and they called me because she's pregnant and they wanted to know how would I deliver this patient, and I said she should have a C-section. Yeah.
Okay. Another question is Dr. Emre Pabuççu. Is it beneficial to give GnRH agonists for hormonal suppression before embryo transfer, either in infertile focal or diffuse adenomyosis cases?
Well, I would say yes, if the approach without GnRH agonist didn't work, but this is a question that many of you can answer much better than I can do because I'm not a reproduction specialist. So maybe Engin, you could answer this.
Yes. We are waiting the response, Dr. Engin Oral. Can I repeat the question for Engin Oral? Is it beneficial to give GnRH agonists for hormonal suppression before embryo transfer, either in infertile focal or diffuse adenomyosis cases?
I believe for the focal cases, it's really beneficial for the GnRH analog before the embryo transfer at least 3 months. For diffuse cases, I am not sure in my practice. And if you look at the literature, there is no answer for this one because most of the cases are the complex and some of them are diffuse and some of them is the local one. That's the main problem. There is no clear classification. Only we have just one paper from the chaperone group. They say for the just if she has the focal one, the GnRH analog is the better than with the other ones. But we don't know the how many months we have to use this one. This is another question. Thank you.
Okay. Thank you very much, Dr. Engin Oral, for your good answer. Another question is Dr. Koray Alter. You emphasize the importance of laparotomy for diffuse adenomyosis. Do you always prefer laparoscopy for an adenomyoma? Do you always prefer laparoscopy for focal cases? I think the question is regarding the laparoscopy for focal adenomyoma.
I think it's important to find a good individualized approach. So yeah, it depends on the case. So sometimes you have fibroids additionally, sometimes you have deep endometriosis additionally. And in most of the cases, we do first a laparoscopy, and then we see what we can do. And then you always can switch to a C-section-like laparotomy, and you can then do perfect surgery on the uterus. So I just want to say that, yeah, we should not always focus on laparoscopy. I mean, we do all our endometriosis cases by laparoscopy. I cannot remember any case that we did open in the last 5 years. But in adenomyosis, yes, I like to do sometimes open surgery. And why not? So it's not forbidden to do open surgery. You know, when you have a good result and you have the feeling that you need your fingers to know exactly what you have to dissect and that you do a better suture with the open approach, then I think that's the best option. Yeah.
Do you believe that BFLAP technique is suitable for laparoscopy for diffuse adenomyosis or not?
Yes, I think it is, but it's difficult to do because you need to do a very good resection of the tissue. You need to spare the tissue. Then you have to suture a lot. So maybe it's easier to do this with a robotic system because the suturing is easier. But as I said, sometimes it's also good to just do the traditional techniques. And the most important thing is that you have a good result. So if you want to do a flap technique, well, you need to do a deserialization of one side of the uterine wall. And this is not so easy to perform by laparoscopy. And what we know from the Ozada paper is that the use, and especially the extensive use of energy devices, is the problem. So when you use a lot of tissue damage by using energy devices like harmonic scalpel or whatever, ultrasound scalpel, or even bipolar energy, this might be an important factor in relation to uterine rupture and wound healing problems. So when you do the open approach, you can, for example, ligate the uterine arteries for a while, or you can just do resection by cold knife, which is also possible by laparoscopy. But yes, to be honest, it's not so easy. And yes, I prefer to do it open. Yeah.
Okay. Another question is Dr. Emine. How do we applicate ICG? How do you use ICG? Do we use ICG during operation or before? How do you use ICG for adenomyosis cases?
Yes, well, this is just in some cases. Today, for example, we did a niche resection, and then we put some liquid with ICG in a very small dilution to the uterine cavity. Yeah, by putting a uterine manipulator, then we put some liquid with ICG to the cavity, and then you can see the uterine niche, because the liquid goes into the niche, and then the ICG effect shines through the uterine wall. And the same happens in some adenomyosis lesions when there's a connection to the cavity, of course. When there's no connection, like for example in adenomyosis, which is only related to the outer myometrium, and there's no connection to the endometrium, then it doesn't work. Okay. So this is something that, yeah, we do in a study, we do this, yeah.
Okay.
But
another question is, again, Dr. Emre Pabucu. Sometimes during fibroid surgery, we realize that we encounter that focal adenomyosis tissue in such cases. Mm-hmm. Do you recommend to remove these portions that detected coincidentally during the surgery, myoma and focal adenomyoma at the same time or coincidentally? Mm-hmm. Do you remove the both of them or not?
Yes, if in that moment you have to ask yourself, will I be able to close the uterus? And if that's possible, then yes, I would say remove it, but you never should end up doing a hysterectomy. Then you have a big problem. And this is what happens. There's also literature on that. So people think they do a surgery on a fibroid and then they end up doing surgery for adenomyosis, and yes, you can lose control. It can start to bleed a lot, and so yeah, that's why the imaging is so important. Yeah, that's why it's mostly important to know before you start that it's adenomyosis or a fibroid.
It depends on the, I think, surgeon's experience whether to go on or not, to stop.
Yes, yeah, because you have to be aware of the problems. Yeah,
challenging surgery. Yes.
Yeah.
Another question is that what should be the minimal interval between open adenosurgery and pregnancy? After surgery, how can we, what is the time? 6 months later, can we get
nobody
knows.
I think it depends a bit on patient's age. You know, when you have a patient 28 years old, then you have time. When it's a patient 30 years old, then you do not have time. So I think this is a factor. I personally believe that 6 months is enough.
6 months.
Yes.
I have 1 or 2 questions as a general questions. Is there any method for predicting uterine rupture in women who have undergone adenomyosis or adenomyomectomy surgery? Is there any method? How can we predict that this lady can happen or can encounter uterine rupture during her pregnancy or not? Can we predict with some objective criteria or not?
No, not to my knowledge. I think it you know, sometimes I see cases that underwent adenomyosis surgery in other departments, and the Center for Reproduction sends the patient because they feel that the tissue above the endometrium is too small. So in some cases, when you do ultrasound, you can see that the endometrial layer is very close to the serosa. And when you have the feeling that this is almost reaching the serosa, or that there's even a fistula, then this might be a risk factor, and then we do additional surgery to close that. But when you do a good surgery and you have a good wall thickness and a good suture, then yeah, I don't know. I mean, still some of these patients have ruptures, and I don't know how to predict this. No.
Okay.
Yeah.
My another question is that, as you know, that there are some papers regarding with the postoperative maintenance therapy after adenomyoectomy surgery.
Mm-hmm.
You mentioned also, for example, the GnRH therapy for 6 months after surgery, after adenomyosis surgery. And some papers also mentioning that additional therapy also is needed after GnRH therapy, and it is called a maintenance therapy. For example, Dionogest, levonorgestrel, at least for 2 years after adenomyosis surgery. Do you believe in this maintenance therapy after GnRH therapy or not? Or do you have any other choice for this kind of therapy?
No, yes, of course, we also use it, and this also applies in patients who do not want to become pregnant, and then it's okay. So the recommendation is that well, you can directly start with gestagenes, or you use it as a continuation after GnRH therapy. But most of the patients, of course, want to become pregnant. That's why they stop the intake. But then after the pregnancy, yeah, they should take something, because when you do adenomyosis surgery, you never take out all the disease. So the problem is going to come back in a way. You know.
Okay. I think you replied all of the questions.
I tried my best.
You tried the best. Speech is very outstanding and very comprehensive. I really thanked on behalf of Turkish Endometriosis and Adenomyosis Society. We have some screen about our Oxford meeting. Could you share, Mr. Uğur, could you share our meeting? We will have a meeting on the 2nd and 3rd February 2024, and in collaboration with Oxford and Edinburgh University. And this is related with mostly with the basic science of endometriosis. We would like to invite you our meeting, and also there are detailed information about website. And this is mostly related with the basic science of endometriosis, and Oxford and Edinburgh University is supporting this meeting, and with our colleagues and with their colleagues. So we wish you to register and also to attend our meeting. Again, on behalf of Turkish Endometriosis and Adenomyosis Society, I really thank your contribution to tonight's webinar. I wish your last words about this meeting, tonight's meetings, please, Harald.
Yes, I would like to congratulate you for your excellent work. I think the society is very active, and it's wonderful to see. And yes, I thank you very much for your kind invitation, and I wish you, all of you, a very good night. I know it's very late already in Turkey, so I wish you a good night and a good weekend, and see you soon. All the best for you. Bye-bye.
Thank you very much. Again, thank you very much for your support. Thank you very much. Kapatabiliriz herhalde. Okay. We are completing. Katılan herkese çok teşekkür ederiz. We thank to all of the participants tonight. Thank you very much.